Good afternoon and welcome to today's webinar. My name is Jodie Sargent. I'm the Education Coordinator from Central Queensland White Bay Sunshine Coast PHN, and I'm really thrilled to introduce the Persistent Pain Management Service from Sunshine Coast Hospital and Health Service, and they'll be presenting the Professional Pain 101 presentation to you today. Before we get started, I'd like to acknowledge the traditional custodians of the land on which we meet today and pay my respects to elders, past, present and emerging. For those of you that are online, and there's quite a few of you, you'll notice on the right-hand side of your screen, there's a chat box. And during today's webinar, you're welcome to submit any questions that you might have of the facilitators. And we'll have a question and answer session at the end of today's webinar, so hopefully they can be answered. But without further ado, I'd like to hand over to the Persistent Pain Management Service to begin the webinar. Thank you.
Thank you very much, Jodie. My name is Hong Nguyen. I'm one of the team leaders here for the Pain Management Service, and it's unfortunate we're not able to have our cameras up to show our faces. So hopefully, the information that you obtain today will still be as effective. So I want to begin by firstly thanking Jodie and her team, PHN, for enabling us to present this education session. We present this annually, usually around National Pain Week, and this is the first time we've been able to collaborate with an external partner for this presentation. So we thank you for the opportunity. I also want to just thank you everyone who's dialed in today. I know there's a lot of people far and wide who have joined us. Thank you for taking the time out of your busy schedules. I believe we have, I think, over 200 attendees. So it's just amazing that we've had a lot of interest in this important issue. So we thank you for your engagement. So I'd like to, just before we begin the education, acknowledge the Gubbi Gubbi people as the traditional custodians of the land on which this event is taking place. I'd like to, on behalf of the team, pay our respects to the elders past, present and emerging. So in terms of who you'll be hearing from us in terms of the team, we've got a great lineup of clinicians. So Dr. Raja Sengupta and Dr. Tanya Morris will represent our pain medicine officers. We have Carl Stubbs, our senior physiotherapist, myself. I'm also an occupational therapist by discipline. We also have Carmen Stewart, our senior psychologist, and we have Matt Hoger, our clinical nurse, speaking today. However, I'd like to take the time to acknowledge Dr. Aditi Chandrak, who's our SMO, and Carla Mayfield, our senior pharmacist, for their contribution in the content today, as well as just the entire team at the Persistent Pain Management Service. So the learning objectives that we will cover today are quite clear and specific. We aim to increase your understanding of how we explain pain, persistent pain to patients. We want to also go into demonstrating the concepts of the self-management, the biopsychosocial explanations around that and how we do this with our patients. And following this, these parts, we'll present a case study of one of our patients, sort of their journey through the pain management service. We'll also cover some basic de-prescribing principles, and as Jodie mentioned, there will be an opportunity for question and answer right at the end of the presentation. We have a couple of team members who are on standby receiving your questions, and what they'll do is they'll gather your questions and try and sort of group them into the main theme. So we'll aim to address everyone's questions if we can, maybe not specifically to everyone's specific questions, but we'll do our best. And so please do use the chat function to ask us anything that might arise. Also, as you know, understanding persistent pain and for your own professional development, there's always room to develop further. And this session today, even though it's sort of targeted as at a level in terms of how we would interact with patients, this presentation won't sort of be delving into the deep science as such. So if you are interested in gaining more of an understanding and knowledge, we encourage you to access courses and programs available. So the Faculty of Pain Medicine has the Better Pain Management course designed for health professionals. And there's also other groups such as the NOI who run their own suite of courses and materials as well. So for those of you who aren't familiar with our service or may know only just a little bit of what we do, we've been around since 2012. Our multidisciplinary team consists of pain medicine specialists as well as other medical subspecialties. We have psychiatry, rehabilitation, as well as AODS, and our allied health team comprises of our pharmacists, our psychologists, physiotherapists, occupational therapists, and allied health assistants. And also we have our nursing team members made up of our CNC and clinical nurses. So basically, although we're based at Nambour General Hospital, our catchment goes beyond our HHS. So we do service patients in the Wide Bay region. Referrals we typically receive via smart referrals or health pathways. An essential component of the referral pathway is the patient questionnaire. And this is vital because we really do need that information coming from the patient's perspective of how their pain in fact impacts on their function. And in terms of just the general model of our service, so we have a self-directed approach here where we inform the patients of their treatment options, and we run a variety of different groups as well as individual therapies. And with that information, we guide them in terms of choosing their own pathways and their own interventions that they wish to engage. So that's the nutshell of our introduction and our aims for today. I'm going to hand you over to Carl Stubbs, our physiotherapist, who will kick off with explaining persistent pain.
Thank you, Hung. I'm just going to start my little bit of session off with a question. A patient comes into your clinic and asks you a simple question. Well, it might be simple for them, but not for us. They say, over time, why is my pain spreading? Why is it getting worse? And why does my pain come on quicker? And why does it last for longer? How would you answer that question? And how would you give the pertinent information to that patient? One way of doing that to engage that complex question to the patient is to use analogy and metaphor. Making the complex simple is a key skill of the clinician, and making your message stick is really relevant and pertinent to their treatment. I like to present my little analogy that I use for some patients, which seems to go down pretty well. It's the burglar alarm analogy. And what I ask the patients to do is just imagine that they've moved into a residential area, the crime is quite high, and the burglary rate is quite high as well. So they go off to Bunnings and go and get themselves a burglar alarm to get that fitted. Now, obviously, they require certain things for that alarm. They want the alarm to warn them of imminent or actual threat. They want to obviously have some accurate information from the alarm. So when the alarm goes off, hopefully they will think that a burglar will be trying to get into the house. Therefore, they can take appropriate steps by calling the police, and the police come along, take the burglar away, and they set the alarm for the next burglar. And this is the sort of alarm system we want from our pain alarm system. We want the pain alarm to be accurate. We want to know about imminent or actual threat. We want to know we want the alarm to be accurate. We want to know what area of the body is under threat, and we want to know how to take appropriate steps. So, if you had toothache, for instance, you won't want to go to an osteopath. You'd want to go to a dentist. Now, with the burglar alarm, some people might get a little bit anxious, fearful, stressful if that alarm's gone off and the burglar has been trying to get into the house. And they may deem themselves they need more protection. So they go down Bunnings again and get a lot of extra sensors. They put sensors all around the house, all around the windows, all around the doors, and they get extra cameras, they get pressure mats, they get lasers. It's to protect themselves. However, increased sensitivity does decrease threshold. And this goes for our patients in regard to their pain mechanisms. A lot of people do get anxious and fearful and stressful for, say, a low back pain, and they deem themselves need more protection because they fear what's going on in the back. And with that extra sensitization, the body can produce extra sensors that actually plug into the neuron membranes and make things a little bit more excitable. So now we've got a lot of pro-nociception going on, which increases the sensitivity of the nervous system, and it decreases the threshold. So with the burglar alarm all set up and you've got extra sensors all around the house, we're now seeing an increase in the activation of that alarm. The alarm is activated more often. It's actually now activated during the day and during the night. But does the alarm equal threat? Not all the time, but the threat is there for the person in that house. So what do we know about that alarm now? Well, it's lost its accuracy, but it's going off more often. And we see this with our pain sensitization as well. We can see that sometimes non-threatening stimuli can activate the pain alarm system. The alarm system is activated more often than usual. And does the alarm equal threat? Well, not all the time, but to that person, the threat is there constantly. And that threat can cause increased anxiety and stress and increase your sensitization even more. Well, because your burglar alarm is going off all the time, Police HQ are really gaining attention for your house. They're feeling that now your alarm is going off so much that you need extra protection. Protection is the priority. So we increase the sentries, the bobbies on the beat, and we get a direct hotline from your house to the Police HQ so they can react really, really fast. And the police also bring in reinforcements. Now that may be in the form of a neighbourhood watch scheme. So now, instead of your house being wired up, it's the whole street, or maybe the next street. So Mrs. Miggins at the end of number 11, if her alarm goes off, yours can go off. And anyone's alarm can set anyone's alarm off. So now we've got a massive problem with the whole street being alarmed. And this is a really good analogy of wide receptive sensitization, what we see in persistent pain. So widening of the receptive fields is something that happens in chronic pain, and this is through central neuroplasticity. The Police HQ in the body is obviously the brain. The brain gains attention of your low back pain and deems it needs extra protection. Once again, it lays down increased sentries. How does that happen? Well, complex neurophysiological mechanisms actually initiate gene transcription, phenotypic switching. We have also increased pronociception. We also have a stoppage of descending inhibition, because these descending inhibition mechanisms tend to keep the sensitivity of the neurons at a good level. We bring in reinforcements. The reinforcements might be from other systems, i.e. the immune system. So now microglia and astrocytes are also come into play. And we also have the waking of once dormant nociceptors, and now the increased awakened nociceptors. And don't forget, one nociceptor can synapse up to with 1,000 other nociceptors. So your receptive fields of pain can be increased. And we call this secondary hyperalgesia and allodynia. And we have a phenomenon called hypersynaptic facilitation, which also facilitates this process. So the recruitment of large afferents like alpha beta fibers, which normally respond to touch, can be deemed a noxious substance. So what does that mean for the protective alarm system? Well, it means for the burglar alarm, the alarm is no longer accurate. The alarm is activated when no danger or threat is evident. However, that person who lives at that house has to constantly tend to the alarm, to switch it off. And this can happen through the day and night. So now they're losing sleep. They can't go to work. They may even have increased anxiety and fear, which also, once again, can impact on their mental health and exhaust their resources. And this is so similar to our pain patients that we see who have got long-standing chronic pain. The alarm is no longer accurate. It's going off unprecedented times. And also when the patient has these alarm systems going off, they have to tend to the alarm. They have to rest, they have to take medications. And don't forget, some of these medications can actually increase the sensitivity of the alarm system. And it exhausts that person's resources. And they become more fearful and stressful and anxious. And that can increase the sensitization of the nervous system yet more. So what do we do about reducing the sensitization of the alarm system? Well, for the burglar alarm, it's easy. We just go back to Bunnings and get our money back. However, for a human organism, there are so many multifactorial inputs to that sensitization that it's a bit more difficult. And to reverse neuroplastic changes is also a long-standing thing. Now, as clinicians, we should be also looking at how we influence a person's nervous system. And we class these as iogenic effects. Now, the one thing I'm going to focus on today is the words that harm. What we say to that patient will have an influence on that nervous system. Say, for instance, you tell a patient that their pelvis is misaligned or it's not symmetrical. That can have a real negative effect on that person, a nocibic effect. Telling a person with low back pain, you need to really strengthen your core because that gives you a stability of the spine. Once again, is very nocibic. We don't intentionally do that on purpose, but these words that we need to stabilize the spine. Now the patient thinks they have a vulnerable spine. They think it's unstable. They think they need to activate their abdominals all the time. This will have a major impact on maladaptive movement patterns and aberrant pain behaviors, which also sensitizes their nervous system. So let's think about what we say and how we say it, because that has a really a positive effect on people, but it also can have a negative effect on people and how they feel about their body. We don't want a vulnerable organism or people to think they're vulnerable organisms. We want them to think they're robust and resilient. These are modifiable, a lot of these sensitization, contributors to sensitization. This slide just shows a few of them. I just want to end with this slide. When we deliver education, there's been a lot of research about how we should be doing that. And here's a few little bits of advice from the research. And there's also things that I've also worked on myself and got through experience. Before giving education works best once you've got that therapeutic alliance with the patient. So if you've got a good therapeutic alliance, the education you give will stick more. It will stick and it will become more relevant. However, if that therapeutic alliance hasn't been accomplished, the patient may not believe or think that the education that you're given is relevant. And they might double down on their maladaptive beliefs. And plus, they may also have a kickback effect. If you are delivering education, try and restrict your messages to 1 to 2 key messages. And that's choose the key message that fits the patient in front of you. Think about the patient's main concerns, or ask the patient, what is your main concern? And then work from there. Use analogy and metaphor where possible. And lastly, think about what you've said to the patient. Why not ask the patient, okay, you've got the education. How would you explain your problem to someone that you know? So how would you explain it to your wife? How would you explain what I said to your relatives? Now, this is quite a humbling experience because you may have thought you communicated really well with that patient. It's got the key messages in, but the patient might just be off on a tangent with what you said. It's so easy to blame the patient for that, but however, it's also we need to question how we communicate with people and make sure we get the key messages to stick with the patient. That's the end of my session. I'm going to hand you over now to Dr. Raja, who's going to also talk a little bit about metaphor.
Thanks, Carl. Hello, everybody. My name is Raj. I'm one of the doctors on the Persistent Pain Management Service. And I would like to just start off my talk by taking off and going back a few things that Carl's mentioned. And I think the 2 key take-home messages that I would like to emphasize. I think the first one is that we really, as health professionals, we need to change our perception and our expectations around chronic pain, because the biggest issue with managing chronic pain in patients is to recognize unrealistic patient expectation and educate the patient to shift that expectation to something more realistic. And unless our expectations match that, that's going to be a struggle. So I think the reason I put up the robot from Lost in Space, which went around scaring Danger Will Robinson all the time, is to emphasize that even before we went into med school or whichever school, I mean, I know there are a lot of other people, not just the doctors on. So before we went into our training, we have this perception that pain means danger, pain means something wrong, and that's very true for acute pain, but does not hold true for chronic pain, and we need to accept this. The other thing, key take-home message from Carl's talk, is that chronic pain is multifactorial. So it's not just tissue damage or nociception which is driving it, but there are environmental and personal factors which are driving the pain. And we need to recognize that there are different factors involved, because unless we identify and manage those factors, we're not going to win. So I've put this up here. These are the key differences between acute and chronic pain. And I think the things that make chronic pain stand out and help us recognize it, apart from the fact that it's usually something that's lasted greater than 3 months, is look for maladaptive pain behaviors. Carl spoke a little bit about it. So typical maladaptive pain behaviors are patients who grimace a lot, who sigh and moan a lot, who have exaggerated labored movements, patients who have unstable postures, patients that overreact during a physical examination. These are all maladaptive pain behaviors. And the other characteristic feature of chronic pain is it will be signified by dysfunction. So a patient who is unable to participate in leisure activities, unable to participate in work, and is having dysfunction is a patient who's got chronic pain. And it's important to recognize it, and because without recognizing it, we're not going to be able to manage it. So if you've got someone with chronic pain where psychosocial issues are playing a significant role in perpetuating the pain, just prescriptions is not going to fix the psychosocial issues, and it's not going to fix chronic pain. So we need to recognize that we need to have a holistic biopsychosocial approach in the assessment and management. I thought it would be useful to put in this international classification of functioning disability and health by the World Health Organization. And as you can see on the left of the slide, you've got body functions and structures, but you've also got environmental factors and personal factors at the bottom of the slide, which play a vitally important role in chronic pain, as we've explained. And that has a significant impact on activity and participation in normal life stuff like work and leisure, and it's the inability to do any activities and inability to participate which causes the dysfunction that I was speaking about. Now, before I proceed further, I just want to take a second to acknowledge that, look, we know that this is incredibly hard. Patients in pain are in a lot of distress, and there is an expectation from patients that, you know, they've come to a health professional to, you know, they're in distress, and their expectation is that their distress needs to be fixed and fix this instance. And you know, while we might feel that, you know, I must do something to fix this distress, I think it's important to realize and acknowledge that with chronic pain, there is no quick fix. And the only way to actually fix the system, fix the problem, is to have a conversation with the patient and start the education process. And it might not happen in one day, and it might require multiple conversations over several periods of time. But at some point, we need to have the conversation, but it's a hard conversation, but the necessary conversation to have. So in the next part of my presentation, I was just going to talk about 5 key common questions that patients often ask me or the rest of the team, and how we use, or I use, metaphors to help them understand why what their expectation is not really realistic and is unlikely to be met, and how we can still help them. So the first question that I often get asked is, Doc, I'm in pain, I can't do anything. How do you expect me to do anything if I'm in pain? Well, what I often tell them in this instance is chronic pain is like the weather. The weather is something that we as individuals have no control over, but the weather has a significant impact on all of us, and there's not much we can do about it. So, you know, you have plans for the weekend, you've got plans for a barbecue, you've invited all your family and friends over, you're looking forward to it, but it decides to rain heavily on the weekend. Now, you've got choices there. Now, you can either choose to stay at home and be miserable, that's an option, or you can go, well, you know what, I can't meet up with my family or friends in the park for a barbecue, but, you know, I can bring them over at home and still have a good time. Or some people can choose to still have fun in the rain. So there's always a choice, and you can still have a good time regardless of the weather. The other thing, that the second question that patients often ask us is, patients believe that we in the persistent pain management service have the magic opioid formula, like we know an opioid combination that's going to work, or we know a particular opioid or a set of opioids that we're going to prescribe, and it's going to fix the pain just like that. So I often use the overflowing bathtub analogy in this instance, where the overflowing bathtub I refer to as the central nervous system, which is having all the notchoplastic changes that Carl talked about, and the bathroom is the periphery where the nociception or the tissue damage is. So patients come and expect us to talking to us about opioids or procedures which are targeted primarily at the periphery, at the peripheral tissue, and damping down the nociceptic effect at the peripheral tissue. it does nothing to address the changes in the central nervous system. So what I tell the patients is that if you've got an overflowing bathtub, what do? You need to turn off the bathtub and drain the bathtub. You cannot deal with an overflowing bathtub by trying to mop up the bathroom. You might win for a few minutes or an hour if you put in a lot of effort, so typical boom busting, but you're never going to get the bathroom dry unless you address the problem at hand, which is the changes in the central nervous system. The next question that we often get is patients get very defensive when we start asking them about, when we do a biopsychosocial assessment and we start asking them about their mental health, their childhood. And I think often there's this perception in the community that those questions generally imply that we are implying that this is all in your head. And so the way I try to explain that, the reason why we need to ask those questions to these patients is because I say that if you are watching a dance, you don't just look at the lead dancer, you look at the entire performance. So if we just focus on you, the lead dancer, and ignore everyone else in the background, we don't get the whole picture, we don't get the whole assessment, we can't help you the best way that we can. So I think it's important to sometimes when you're assessing a patient in chronic pain to step back, sort of not get on the stage with the patient to get a and do a microscopic examination of the patient, but to step back on the balcony, look at the entire stage, look at all the factors like, you know, what was their childhood experience like, what was their financial stability, what's the relationship like, and then come up with a comprehensive management plan which addresses all these issues. The fourth question that we often get is usually by the time patients have come to see us, they've been to the physiotherapist or been to the psychologist, and they're like, you know, I've tried them, it hasn't really helped. Well, I use the building the house analogy here. The difference between seeing a physiotherapist or a psychologist in isolation compared to seeing them in a multidisciplinary team like ours is that no individual therapy can help in chronic pain, but if the cumulative effect of all the different things has a significant effect. So what I try and tell patients is that when you build a house, the builder doesn't just hire a concreter or a tiler or a plumber in isolation. He hires everyone he needs to build the house, and everyone works together to build the house together. So everyone does their part, and you get a bit of benefit, and it's the cumulative effect that gets you the best result at the end. And the fifth and final question we usually get is, what is self-management strategies? Because we kind of emphasize on that, and how is that going to help me? So what I talk about the metaphorical pain toolkit, that our role here is to help the patient develop a pain toolkit. This pain toolkit will have different tools, and different colleagues of mine will help the patient develop each different tool. Within these tools, there's the hammer. Everyone's probably tried to hammer a nail and hit their thumb instead. So you have to be very useful, and you have to be very careful with the hammer. So the opioids are like a hammer. They have a role, but we have to be very careful because they can be harmful. And there are a lot of other tools, and what I tell them is that you cannot build, like say you're planning to build a chair, you need to use every different tool. You can't just build a chair using a hammer. So the idea is you build different tools, and then 2 years from now, 3 years from now, if you're having a bad day, you pick and choose whichever tool you think will work best for you and use that to manage and get through your day. So that's some of the things that we often get asked, which you might get asked, and feel free to use these metaphors or modify them as you would like to use them. Now, I'm going to hand over to Huang at this point, and she's going to talk you through a bit more about biopsychosocial self-management.
Thanks very much, Raja, for the handover. I just wanted to summarise the learning objective that Carl and Raj have just covered, which was explaining pain. We use metaphors and analogies all the time. It's a daily practice here in our work because we know pain is incredibly complex. It's a complex concept to understand and explain. So if you can weave metaphors with your interactions with patients, that's certainly a great place to start. So in regards to the biopsychosocial self-management approach, the goal here is essentially to improve function. The focus of reducing pain is a byproduct of that focus. And we, of course, want to hope that the pain does reduce, but that isn't the focus. Primarily, it's the functional aspect. So the key learnings that we'll cover over this next few slides is to understand that without addressing the biopsychosocial contributors or load factors, it's very unlikely or very challenging to influence and moderate pain. Understanding the patient's stage of change is very important. We need to make sure that we meet the patient in terms of where they're at. And so if they're pre-contemplative in terms of their ability to change, then education is key. And it may be possible, it may be likely that discharge, an early discharge might happen for that person. However, if a person is contemplative and they're ready and they're in that action phase, then they'll certainly benefit from active management strategies and therapies, such as the services that we provide here in the pain service. So we focus our strategies and treatment sessions around that self-management approach, which is very similar to how you would approach any other chronic conditions. And we often explain this to our patients as well, because they, as you know, have many comorbidities. So self-management is no different to how one would manage asthma or diabetes, high blood pressure. So it's all about lifestyle management and doing things that can potentially change their life in a better direction. So on this slide is just a snapshot of, and not limited to, in terms of all the different types of strategies or interventions, treatment approaches that can assist somebody's self-management approach. And so they include things such as cognitive behavioural therapy, to vocational rehabilitation, sleep hygiene. And in fact, sleep hygiene is probably one of the #1 issue that we see in our cohort. Tai Chi, GMI, sensory modulation, hydrotherapy, relaxation, hypnosis, graded exposure to activities, communication or either interpersonal effectiveness, activity modification, problem solving, neurodynamic rehabilitation, and motivational interviewing is woven through all of our practices. So this is, I guess, just an overview of that mind and body focus that we have here, and knowing that with pain, there's a lot of different treatments that can help, and all of these are that non-medical non-medical focus. So as you can see, there's a lot of opportunities here for patients to get help. So we recognise that when formulating an action plan for patients, there could be a lot of areas in that biopsychosocial space that requires addressing, and so it is often difficult to sort of work out what to address first. So we like to sort of take a one task approach here. So focusing on just one main thing at a time. So from a functional perspective, it could be taking on a paced approach. From a lifestyle perspective, it could be incorporating exercise into daily life again. It could be improving stress management in the home. And the benefits of having this approach is, it's obviously, it makes sense. It improves their self-efficacy, their confidence in that they can do something over their pain, it improves their internal locus of control, provides them with active strategies for coping, improves quality of life, and reduces medication, and the list goes on. Just in terms of that paced approach, as Carl pointed out with the nervous system involvement, the reason why a paced approach is important is because we know that nervous system is highly sensitized. So any new changes is going to likely to set off that heightened pain response. So with any strategies, doing things in a nice paced approach sort of just helps keep the nervous system happy. And all of our disciplines here focus on pacing through their own discipline lens, and this is something that we all should be doing. So in terms of understanding, I guess, pacing, it's important to have a good awareness of the activity approaches that a person is undertaking, whether that's helpful or not. There's also other factors that might contribute to why somebody's activity approaches isn't optimal. So those things can include their own core self-beliefs around activities, around roles, around schemas. So it's important to sort of be aware of those other things. And where possible, certainly sensory modulation can help with that paced approach as well. So incorporating things that might provide comfort, ease, calm, relaxation while they're engaging in active treatments. So just over the next couple of slides, I want to illustrate the common activity patterns that we see in people with persistent pain, and these are not something new. I'm sure we all relate to these because often our activity patterns begin, from our own sort of, growing up and things that we've learned in terms of how to approach activity. So boom and bust. I mean, for most people, we get into this pattern because it often enables us to achieve goals, to develop skills quite quickly, to problem solve on a day-to-day. But when you've got a chronic condition that impacts on your time and energy and what you can do, this activity approach isn't helpful or healthy. And in fact, long term, over time, the amount of activity a person can do actually reduces. So you see this sort of peaks and troughs of peaks of activity followed by prolonged periods of rest, and then another peak once a person feels better again, and then rest for prolonged periods of time. And this isn't helpful for a range of different reasons. The other pattern that we commonly see, and I'm sure we can all relate to when we have illness or we are recovering from injuries or things, is this approach to activity where we do nothing or don't do very much. But for people with persistent pain, often this avoidant pattern is driven by fear, fear of causing more pain, fear of not being able to complete the activity in full, fear of letting others down, so not doing the activity at all really. And you see a marked decrease in terms of what they can do. But in this pattern, what we see is people not, because of fear, they're not able to sort of perform at their potential or their capacity. So they work underneath their tolerance. So both patterns you could we could see in a person. So it's possible to have mixed patterns in terms of seeing when a patient presents with poor activity habits in the context of pain. So one thing that can help and that I've emphasised is this pacing approach. So what this looks like in terms of our activity is working with the patient, setting out some meaningful goals with them, and often using an acceptance approach can be really helpful. And in fact, if a person is at that point of acceptance of, okay, understanding that yes, they might that pain might be something that they will have to live with for forever or quite a long time. Acceptance opens up their mindset of being able to take on new information and new learnings. But we know that everyone is at different stages of acceptance, and this can fluctuate. Starting low and going slow with whatever activity or intervention. So it's important to find a nice baseline that a person can tolerate, and then adjust the dosage over time by small increments. So it's about sort of working under the radar of that nervous system. Taking breaks before pain tells you to. Now this is really hard to do, and it takes a lot of practice. So we often tell our patients that if you take a break before pain gets worse, you actually, over the course of the day, they'll find that they can actually do more, and that's because they're sort of working, sort of having the breaks before the pain tells them to. And the breaks doesn't have to mean stopping completely, which we know can be hard for a boom and bust personality. So it could mean changing an activity where you're using a different set of muscle groups, a different set of movements. It could mean incorporating mindfulness, or using external aids such as timers and things. So there's many different ways that breaks can look like. And I think and then obviously in terms of other forms that breaks can take shape, sensory modulation. So using different strategies that can bring soothing or more alertness into a person's day-to-day function and focus. So I'll now hand you over to Carl, who will go over the exercise domain of self-management.
Okay, thanks, Sam. Well, I suppose as a physiotherapist, it's my domain to talk about exercise and why it's important in chronic pain. Now, exercise has very good efficacy in a lot of chronic conditions, and chronic pain is no different. There's lots of reasons why. I mean, that is a webinar in itself, so I'm just going to go over some pertinent points that I think are reasonably important. Now, there is a phenomenon called exercise-induced hyperalgesia, which is basically where we get more activity with the descending inhibition systems, which we know is really being basically stopped or put on slow because of the excitatory facilitation that goes on because of chronic pain. So in some chronic pain conditions, we can get some exercise-induced hyperalgesia, but some are better than others, and that's still a good research question. We talk about systemic inflammation because a lot of our patients have got chronic comorbidities and they're deconditioned, and we do see a lot of people with metabolic syndrome, which causes systemic inflammation, and pro-inflammatory mediators are at the site of that. And exercise actually has been shown to bring in anti-inflammatory mediators, which can actually counteract that pro-inflammatory concept or the phenomenon. Obesity obviously is another reason why systemic inflammation occurs, and obviously some autoimmune conditions as well. So having some anti-inflammatory mediators and neurotransmitters around is a really good way to desensitize that central nervous system. Obviously, we know about increased circulation, but we're talking about hypoxic tissues here because a lot of our patients don't move and they avoid movement, and that's because they're in pain. And once again, they're in that cycle now where they actually increasing their sensitization. And that's because they've got unhealthy tissues, and also unhealthy nerves, an unhealthy central nervous system. So moving around and getting all the circulation and getting the nutrients in and the toxins out is a really great way of trying to reduce that sensitization. We know about the improvements of health, bones and tendons, and that's straightforward. And also, we know, obviously, with the role of the brain, we know that exercise does induce increased descending inhibition. It gets the endogenous opioids moving, and we can actually have an impact on that sensitized nervous system. Now, ensuring that the patients realize that this isn't something that happens in a day or in a week. These things do take time to actually, when you get the benefit. Obviously, looking after, when you've been for exercise, as you may know, if you exercise, you just do feel better after exercise. And I think that's more to do with increasing the self-efficacy of the person, because they've actually completed something and actually accomplished something, and that actually improves self-efficacy. And also it improves their internal locus of control, because to know that I can do this again, and hopefully I can keep doing this. So we're trying, that's another thing we're trying to promote with exercise. Now, this is a massive question, how much exercise, because the research hasn't come to any decision about exercise. And I don't think it ever will, because I think our individuals, or human beings as a whole, are too individualized. They've all got different genetic makeup, they've all got different tolerances, they've all got different experiences of exercise. So I think starting a person on exercise, particularly with a pain condition, is going to be an individualized thing, and you've got to really think about that before you start giving an exercise program to anyone with chronic pain. And I think also it's also pertinent to say that we obviously start off little and often, and we need to find that right dose, because obviously baselines are really hard to establish. Just like we do with medications, we start people on a low dose because we don't know how they're going to react and what the adverse effects of that medication will be until we try it. And it's the same thing with exercise. And as long as you tell that patient, yeah, we're going to try this out, see how it goes. If you find that you have increased pain, don't worry. That doesn't mean we've harmed you. It just means we've just excited that nervous system up a little bit and just got you riled up. We just need, and then we can adjust that dose to suit. So finding the right dose is hit and miss. And I think it's an experiential thing that the patient has to go through to try and get their own account of what the right dose is for them. And that's best done with a diary, or not a regular contact with a physiotherapist. Now, as a physiotherapist, I call myself a coach. I'm an actual coach rather than a physiotherapist. I'm coaching this person through an exercise and to get them to establish the baselines, and then we work from there. In the initial stage, frequency is better than intensity. And to say that, I'd rather get someone doing a daily walk of 10 minutes every day than one session of 40 minutes and then they miss a whole week out. Because the frequency is all about building a habit. Yeah. So we need to build that habit, because the habit is building self-efficacy, and we can also improve that patient's tolerance over time. So the frequency is better than intensity. And people ask, well, what's okay? Is it okay to be in pain while I exercise? Personally, I think exercise, I don't know an exercise that is pain-free. So when we talk about having chronic pain and exercising, we have to obviously think, yeah, we're going to stress the body, but in a good way. And you might feel a little bit uncomfortable. But as long as you can tolerate that and you can monitor it, then that's fine. So when we talk about monitoring the 24-hour aftermath after an exercise, what we're looking at here is the fact that the person has the ability to manage themselves. So if they find, oh yeah, I was a bit, yeah, I did the walk, it was fine. I was a little bit in pain for an hour and a half afterwards, but I went back to baselines and I could still function, and the next day I was fine. That's a green light to keep going. However, if they say, well, actually, no, my pain was increased, I had to take more medications, I couldn't sleep, next day was terrible, then we know we've got the dose wrong. Now, let's not blame the exercise. That's the boogeyman. Okay, we don't blame the exercise, we blame the dose. So we just adjust the dose. And remember, when we talk about what type of exercise that patient requires, well, that's again is a very ambiguous area in research. We know for chronic lower back pain, for instance, there's no one exercise better than another. But so that gives us a wide area to work with the patient, because the patient can have a choice of what they do. I think the principle is that we need to build regularity and frequency of movement. And the way we do that is we give the patient something they enjoy. Now, sometimes we have to be specific with our exercises, depending on the patient, but sometimes we can have a wide field to choose from. Increasing the dose is a key thing as well, because some patients are not really very realistic. So when they say, right, I'm doing a 20-minute walk, I'm going to increase the dose to 30 minutes, well, that's a 50% increase. Not even elite athletes can go to that massive amount of increased dose without having an adverse effect or an injury. So we've got to keep that the dose and increasing the dose realistic. And I usually work off a ballpark figure of like 10%. So it's a bit like what Hung was saying with the pacing. It's graded exposure, and we do increase the dose when the patient is ready. And when the patient, what I usually say is, if you're doing an exact dose for 2 weeks and everything's fine, then let's start to increase it. Because don't forget, just because a patient has pain doesn't mean they're not robust and they're not resilient. They are strong, but they just have pain. They can adapt, but they have pain. They're an adaptive organism. So if we stress them enough, regularly enough, they will adapt to that stress and build load and build tolerance to that load. So this is what we're working off. It's exercise physiology, but it's for a sensitized nervous system. And over time, you get what we call the habituation effect, where the patient gets more and more used to stress and load, and they can tolerate more, and their capacity to tolerate load increases. So they're the main points I'm going to bring to you, and I'm just going to hand you over now to Carmen, who's our psychologist.
Thanks for that, Carl. That was fantastic. So just before I jump into pain, stress, and psychology, I want to thank everyone for the questions that are coming in thick and fast. Absolutely fantastic that everyone's so absorbed in our seminar today. It makes us all feel very special. So I want to talk to you really briefly about stress and psychology. So one of the main roles of a psychologist on a pain team is actually to assist patients with stress management. As Carl and Raja have suggested in earlier slides, the metaphor of a patient continuing to attend to a pain alarm time and time again can be used in many different contexts. The model that you see in front of you on the screen this afternoon is actually taken from Paul Gilbert's 3 emotional states model, and it's something that can be used to help educate patients on stress management. It explains the interplay between stress and avoidance of pain quite well. So we know that chronic pain overall is associated with an overactivity of the sympathetic nervous system. And in layman's terms, what you would probably see with your patients who have pain is pain causes them stress and distress, but stress and distress also causes further pain. So it's no great leap to identify that your patient has an overactive threat system. What is also the case is that pain patients usually have an overly active drive system as well. And the idea of the drive system is different from the threat system, which is obviously fight and flight and freeze. It's a system that seeks out relief from pain or solutions to pain, to fight against pain or drive away from pain. So unfortunately for most pain patients, though, this almost becomes a compulsion or a daily pattern for them, using avoidance to cope with their pain. Often these attempts are quite passive in nature. So it might be taking medications, increasing medications. As a result of those medications, they're more sedated, they're spending more time lying down or resting. And then what tends to follow is catastrophizing and worrying endlessly about the pain and when the pain will end. So as a result, they're continuing to tend to their alarm. The threat system grows larger, the drive system grows larger, and it becomes a bidirectional relationship. All of the time, what happens is there's physiological arousal as a result of both of these systems. And of course, more tension in the body leads to more pain. So what we want to try and do is activate patients' soothing system. Our patients generally have an underactive soothing system. It's underdeveloped. And what does tend to be the case is this is usually because of developmental factors. There may be trauma or attachment issues in their background that has led to this underdevelopment of their soothing system. So of course, the goal of psychological treatment is, whether it be individual or in groups here, is to assist patients to be able to strengthen their parasympathetic nervous system, increase their ability to self-soothe, to drop down into the relaxation response, become less reliant on avoidance, and utilize those natural painkillers that we have within all of us to dampen down all of that descending inhibition. So how do we do it? So look, psychological intervention here at PPMS can take many, many forms, but one of the things, I suppose quite a few of the things that we make sure that we cover is breathing strategies. We know that over time, pain patients become chest breathers, not belly breathers, and there are huge inherent issues with that. We teach a lot of mindfulness strategies, both individually and in our group programs. Assertiveness training is about trying to make the most of the social supports around them, but also accessing supports or enhancing supports that they don't have. We all know that a person is less stressed if they feel like they're supported emotionally, informationally, and instrumentally. Those all need to be ticked off when it comes to chronic conditions. Hung has spoken before, and the other presenters have also touched on sleep hygiene. We know very basically that a poor night's sleep for our pain patients increases pain the next day, but pain increase, interestingly, is not predictive of poor sleep. So the reason why we teach sleep hygiene and techniques and hints around sleep is often patterns of sleep become hugely problematic when a person has pain. And obviously decatastrophizing, CBT, cognitive behaviour therapy approaches, and acceptance and commitment therapy approaches are really important with our pain patients, changing the way that they think about their pain. But we also emphasise coping strategies in moderation. If you're entirely relying on mindfulness, as Raja had said earlier, if you just have a hammer in your toolkit, it's not going to be effective for you a lot of the time. You need to build up a range of strategies, and that's what we attempt to do here at PPMS. Okay, so moving on now, I'm just going to introduce Matt. Matt's one of our clinical nurses, and he's going to run through a case study about JT.
Okay, thank you, Carmen, and good afternoon. Today's case study is about a gentleman by the name of JT, and hopefully JT's case study today will give you an overview of the process and the journey through our persistent pain management service. Key pain inputs. JT's presenting problem was non-specific chronic lower back pain and neck pain. Our triage screening tools indicated JT had maladaptive pain beliefs, passive coping strategies. He was pre-contemplative and didn't appear to have any real goals. As a team, we're also concerned on his reliance of opioids, giving his OMED of 80 milligrams. At this point, I want to make note that patients sometimes present to PPMS with goals of which we cannot assist in. For example, we do not assist with completing NDIS applications, nor do we assist in insurance claims or liaise with Centrelink. These goals are inconsistent with our aim and our rehabilitation model. Assessment. Like JT, the majority of our patients first would be triaged to our Pain 101 education program, followed by an assessment. And during JT's multidisciplinary pain team assessment, the following individual multifactorial contributors were identified: functionally, psychologically, and immediate stresses. Moving on to treatment. As JT lived a distance from Sunshine Coast, he could not attend a number of our sessions. However, he utilised the range of our allied health clinicians for intervention via telehealth, face-to-face, and phone. And now, due to COVID-19, all patients near and far have access to all of our group programs and individual clinicians via telehealth. Further treatments. JT's treatment consisted of a rehabilitation approach utilising acceptance and commitment therapy model. Some examples of our approaches are pain education, goal setting, daily activity planning under acceptance and commitment therapy therapeutic framework, movement strategies including commencement of hydrotherapy-based walking program, experiential coping strategies including diaphragmatic breathing, Unhelpful thinking styles were targeted, and the resumption of leisure activities. Results. JT's standardised outcome measures collected prior to and upon completion of treatment revealed significant positive improvements across all of the measures, including improved self-efficacy and decreased distress. JT was also able to reduce and eventually cease opioids after liaising between our pain specialist and his GP. This reduction was achieved by the commencement of a structured titration regime. Functional results. As well as improvement in psychological measures, JT also improved in functional measures. These included driving both short and long distances. JT re-engaged with household duties such as cooking, home renovations, attendance at school functions, church events, shopping, and new friendship networks. Importantly, JT drafted his own flare management plan. He acknowledged his pain, while still present, no longer affected his activity engagement. Psychological results. JT's mental health had been of a concern during intervention. However, upon discharge, JT reported less fear of movement, so decreased kinesiophobia. We noted his attendance at hydrotherapy potentially changed the least. However, resumption of household chores, roles, and socialisation were taking up more of his time. Finally, JT's daily exercise became walking his 3 children to and from school. Hopefully, this quick overview has added an understanding of the effectiveness of our service and what PPMS can offer and achieve. Now I'll hand you back to Dr. Sengupta.
Thanks, Matt. All right, everybody. So I'm just going to talk about painkillers and de-prescribing in the next bit. Just a point to note that we're only going to be talking about pain medications in the context of chronic non-cancer pain. We're not going to be talking about pain medications managing cancer pain or in palliative care situations or in acute pain situations. So things that we're going to be discussing right now are a general overview of different pain medications, when to prescribe, when not to prescribe, how to de-prescribe, challenges with de-prescribing, how to prescribe safely. We'll touch a bit briefly about the law and opioids, and we'll go over, there's a slide about recent PBS changes. All right, so everyone is probably very familiar with some of the non-opioid analgesics. So there's paracetamol, there's a bunch of different NSAIDs. I just wanted to highlight some of the adjuvants that we can use and which can be very effective in some situations. So the old-fashioned tricyclic antidepressants, nortriptyline and amitriptyline, can come in very handy in neuropathic pain certainly, but also in any chronic pain. We also strongly recommend duloxetine and venlafaxine, particularly if the patient has a concurrent mental health issue which requires an antidepressant, because they are also very useful, particularly addressing some of the central nervous system changes. Pregabalin and gabapentin are very useful in neuropathic pain, and carbamazepine is something which has got very good evidence in trigeminal neuralgia. All right, so moving on. Right, so when do you come across a patient on opioids? There's the dreaded inherited patient. So if you are a GP, a new patient comes to the practice or has been discharged from the hospital and has been handballed to you on a huge dose of opioids, or if you're an ED and a patient presents with pain and they're on a large dose of opioids, or you're seeing someone else's patient in the outpatient and they're on a large dose, or sometimes it's a patient that you started on opioids. Now, before we go any further, I think it's important to talk about the oral morphine equivalent. And the oral morphine equivalent is very important because it helps anybody when in pain medicine, when you're talking about a patient and you're talking about the different opioid doses that they're on, converting them goes to oral morphine equivalent standardizes the dose and helps everyone understand how much a patient is on. So the Faculty of Pain Medicine has done us a huge favor. They've come up with this app, which is available on Android and iPhone, and you can easily download it for free. And I've got it on my phone and I use it every single day. So it's a very useful app. It operates on a traffic light system. So you basically, when you open up the app, so as you can see, you've got the different opioids that are available in Australia, and you put in the dose that your patient is on, and then you hit the go right up at the top on the right hand side, and it converts all whatever opioids your patient's on into the oral morphine equivalent. So for this presentation, I put in 101, and as you can see, as soon as you hit 101, it comes up as red. So red means stop. That means that they are on a dangerous dose of opioids. Anything between 41 and 100 will come up as amber, which means take care, pause and take care. Anything 40 milligrams and below comes up as green. So you're okay at that level from a safety point of view. So I would strongly recommend that you use this app for every single patient, and particularly when you're thinking of converting opioids from one opioid to another, always use this app. So the next thing to remember when it comes to opioids, the first line of the Hippocratic Oath, first do no harm. So ground rules for opioids in chronic non-cancer pain, they are not recommended for longer than 3 months. The risks outweigh any perceived benefits. Perceived benefits include patients coming in telling you that, doc, the pain medications really help me. That's a subjective benefit or a perceived benefit. So to justify ongoing opioid prescription, the patient must have objective improvement of function. And what I mean by this is, say you got a patient who comes to you in chronic non-cancer pain, and they tell you, look, doc, I can't cook, I can't clean myself, I can't shower myself, I can't dress myself because I'm in so much pain. So you start them on some opioids. At the end of first month, they go, okay, fine, doc, I can now do all of those things, and I can do a little bit of household chores. Second month, they can do household chores, they can go out and get the post themselves. At the third month, they're well enough now and the pain is well managed that they can go to the shops. So as you can see, in every month their functioning has improved. Now they're able to get out of the house and do things. At this point of time, they need to start coming off their opioid dose. So if at any time they don't keep increasing, and once they reach optimum function, the opioid dose doesn't start decreasing, their functioning has plateaued. So if their functioning has plateaued, then it's evidence that the opioids are no longer working, and we need to think about doing something else. Right, now a little bit about what evidence there is for chronic non-cancer pain. So there's been a few recent trials and that I've highlighted at the bottom of the slide. And as you can see, that there is not really any clinically important improvements found with opioids, and they were non-superior to non-opioid medication. And Carla, our pharmacist, very helpfully put in this graph. It shows that while the effectiveness of opioid over time gradually decreases, the risk of harm increases and increases exponentially. So we need to keep the risk-benefit ratio of any intervention that we're doing in mind all the time. So what are the risks of opioids? Well, the ones that we're most worried about is we see respiratory depression and its impact on sleep-disordered breathing. This is the most important one. There's increased risk of falls and fractures. There's hormonal effects, particularly in men, which leads to reduced libido. And particularly with the COVID-19 pandemic, that's something that we need to keep in mind, is chronic opioid therapy compromises your immune system and increases your risk of infection by being on it. Now, here are some facts and figures, I think, which are important to take home from today. So 80% of opioid users will experience at least one adverse effect. So that's for every 10 times you prescribe opioids to patients, 8 of those patients will have some adverse effect. Every day, opioids cause 3 deaths and 150 hospitalizations Australia-wide. So I think we really need to step back and think about the risk that opioids are causing to patients, and the continuing prescribing, the potential risk that we're putting them with continuing prescribing. The other thing that we need to keep in mind in regards to opioids is something called opioid-induced hyperalgesia. And this is where opioids, not only do they stop working and because people develop tolerance, but opioids actually, after a point of time, they actually worsen the central nervous system changes that we've spoken about. So they actually actively contribute to the notchiplastic changes that are happening, and they make the pain worse. So the very opioids that you're giving to your patient to manage their pain is worsening the pain. So that's something we also need to keep in mind. So the take-home message so far is that if objective functioning isn't improving, it's time to de-prescribe, and that's a perfect segue into de-prescribing. So if you've got a patient on opioids with chronic non-cancer pain, they should not really be on immediate release opioids. Immediate release opioids are only indicated for acute pain short term. They're not meant to be used long term. Ideally, they should be only on one long-acting opioid. So there's no reason why they should be on 2 or 3 different opioids. If there is an acute flare, always use simple analgesia as your first line. If the patient is in crisis and having a really bad day, you can consider one of those IR opioid, but avoid it as much as possible. Now, the other thing that's important to keep in mind when you're prescribing is to think about polypharmacy and its effects on your patient. And the one thing that we must be very mindful of is using co-prescribing benzodiazepines with opioids, because remember, opioids cause respiratory depression, so do benzodiazepines. The combined effect can be catastrophic. So if your patient has an issue with sleep, and yes, lack of sleep can definitely impact on chronic pain, so it's important to address it, but do not try and avoid using benzodiazepines to address it. Use sleep hygiene, use something else, don't use benzodiazepines. And make sure that your patients are on the maximum permissible dose of simple analgesia before going to opioids. As I think I've made this point before, if they have an affective disorder like depression or anxiety and they need to be on an antidepressant and they have chronic pain, consider duloxetine or venlafaxine because they're very useful in these situations. And if your patient has neuropathic pain, consider antineuropathic drugs. Duloxetine is a very good antineuropathic drug, and so is Endep, and so is pregabalin and gabapentin. Now, NPS has a very good opioid tapering algorithm, and I think that it's a perfect document to refer to if you ever have to consider an opioid taper for a patient. And we thought we would just go through this tapering algorithm because it's a really good algorithm. So NPS also suggests that you check for co-prescription of benzodiazepines and you rationalize to a single opioid, like we said. And NPS also says that, if the patient has no meaningful improvement, so no objective improvement in pain or function, that you need to reconsider having the patient on opioids, and also obviously screening for if there's any evidence of aberrant behavior, it's time to rethink your opioids. If the patient doesn't agree to de-prescribing, then maybe assess for substance use disorder, because we have a very low threshold for substance use disorder. I'm not saying every patient has a substance use disorder, but it is out there and it's something to look for, because people with substance use disorder need the help to manage the substance use disorder. Substituting opioids for the substance that they have a disorder for is not a very good long-term solution. So screening for dependency can be hard. Some cases it's very easy to pick up someone who's dependent, but some cases it's not. So the opioid risk tool is a validated risk tool for screening for dependency. It's very easy to administer and easy to use, and I've put it up here on the slide. So you can use this, and if they score greater than 8, then they are high risk. Just a quick word about legal requirements in Queensland. So it is the law in Queensland that The expectation is that whenever you're prescribing opioids, you are screening for dependency, and if they are dependent, that you are registering them with MMU. So if you're not registering with them with MMU, MMU assumes that in that instance that you have assessed the patient not to be dependent. So the expectation is that you have to screen for dependency for every patient that you prescribe opioids in, and the ones that you think are dependent have to be registered with MMU. Right. So continuing with dependency red flag, most of you would be very familiar with most of these red flags. I just wanted to highlight the unsanctioned dose escalation because that's a very common one that we see, and that's the one that kind of flies under the radar. So the common thing is someone's been prescribed endone 5 milligrams twice a day, PRN, and you've given them 5 milligrams twice a day, but then you find out that they're actually taking 10 milligrams twice a day. That is an unsanctioned dose escalation, and that should make you think, is my patient dependent? Okay, the other ones, concurrent substance abuse, multiple prescribers, early refills, tampering, diverting, injecting opioids, I think everyone's familiar with. So going back to the algorithm, so you've thought about it and you've had a conversation with the patient and the patient's agreed to de-prescribe. So NPS gives you the option to do a fast or slow taper. I think our recommendation would be to always go for a slow taper. So you've converted all their opioids into the oral morphine equivalent and converted to one long-acting opioid. And then you drop the dose between 10 to 25%. You can go up to 25%, that's fine. In fact, it's probably better to go up to 25% because of the risk of incomplete cross tolerance. I'm not going to go into that, but I'm not going to go into that today, but you can safely go up to a 25% drop, and the drop by 25% every month and keep dropping till we get them down to at least below 40 milligrams, which is the safe dose, if you remember. If you can get them to 0, great, but at least get them below 40 milligrams of oral morphine equivalent. Now, if you started the taper and the taper hits a roadblock, then you need to pause and reevaluate. Do the dependency screen again. If they are dependent, the addiction services would be your first port of call. If they are not dependent, we are your first port of call. Right, quick word about safe prescribing. So when it comes to prescribing, remember the 5 A's. So remember, check with the patient if their activity is improving. So activity of functioning is improving. If analgesia is improving, screen for adverse effects, screen for aberrant behavior, check the mental health. Make sure you have a written contract with clear goals and plans in place, and consider stage dispensing if there's any risk of aberrant behavior. Now, when you do start de-prescribing, you might have issues. So you might have a patient come in and say, look, doc, I'm not tolerating the withdrawal, and maybe you're going too fast, and maybe I'm going into withdrawal. So bear in mind the objective features of withdrawal are the patient should be tachycardic, they should have GI symptoms, runny nose, they should be insomnic. So if those are not present, maybe consider that this is more subjective withdrawal and the patient might be psychologically attached to the opioids, and that's then a conversation to have with the patient. We need to educate patients when we are with de-prescribing that pain flares are expected and normal, and we should have a strategy to manage pain flares, and that strategy should include and perhaps be restricted to simple analgesics. Education is essential. You have to get, as we've said before, you need to get the patient's expectations right. You need them to realize what is achievable, and you need to get them on board with your plan. You're not like, instead of just you telling the patient, there are a lot of online resources that are available. You've got Reboot, MindSpot, Pain Toolkit. Right now, because of COVID-19, the federal government's made quite a lot of them free, so that's very useful. So use these resources. And as we said before, remember my analogy about building a house. You get everybody on board together. So if there is a concurrent mental health issue, if there is concurrent deconditioning, get the physiotherapists involved, get the psychologists involved. Now, I appreciate out there in the community with Medicare restrictions that might not always be feasible, but do the best that you can. So I just thought I'd put up some of these resources that you can use, so for you to peruse later. Right, and I'll just touch briefly on the PBS opioid restriction, but I think by now you guys would be quite familiar with them. But as you know that you can only prescribe up to 2 weeks now, and anything more than that you need an authority. And if you've got a patient who's on opioids for longer than 12 months, a second medical professional has to sign off on that. And that can be anyone in your clinical practice or a pain specialist. Right. That's me done about pain medications and de-prescribing. I'm going to be handing over to Carmen next to finish off. Thank you.
Thank you so much for that, Raja. Okay, so we're starting to wrap up, everybody. I hope everyone's still wide awake given the dreary weather outside. So just some key takeaways from today's presentation. Hopefully today has assisted you in understanding and being able to explain to your pain patients the necessity of pacing, exercise and stress management, but also the idea of rationalising medication where possible. Unfortunately, due to technological issues, we wanted to desperately show you one of our recent productions here from PPMS. We received a beautiful grant from Wishlist Foundation to produce 5 different patient videos that explained exactly what we do here and showed patients' journey through the service and the changes that they had made as a result of multidisciplinary input. We really want you, if possible, to jump onto our website after this webinar this afternoon and just check them out. They go for about 3 minutes each. So it's probably an extra 15 minutes or so of your time, but we think that they are absolute gold. We're hoping that you may be able to share them with your pain patients to assist those patients who feel hopeless or amotivated or lost in the system, but also to explain to patients exactly what we do. And the overall goal really is to reduce the stigma of how the public view persistent pain. Ironically, this coincided with National Pain Week for next week, being the topic of the faces of pain. There'll be some social media releases through the HHS Facebook page and potentially some media over the next week coming from PPMS to give a little bit more information out there to the public about persistent pain. And before finishing and going to our Q&A summary, just want to give you all a bit of a pathway or a road map to the service. Very basically, once triages are received via health pathways or smart referrals, each patient is triaged into either Pain 101 education, which is obviously very similar to what we've done today with the patient hat on, the medication action plan group, which is focused on being able to give patients the information that we have about medication titration and both the goods and the bads of opioids and other pain medications. Alternatively, patients may be triaged into an individual appointment, which might be with an SMO, or it might be a member of the allied health team. Following either of the groups, the Pain 101 or the MAP group, patients are given a post phone interview, and it's determined then, as Hung had said earlier in the piece, this service really is a bit of a choose your own adventure. So it's up to them to choose what they want to do after they've attended that group or the individual assessment for the first time. They can choose to continue with individual assessments with another member of the team or intervention, or move into one of our workshops. As a result of COVID at the moment, we've had to pivot. We're now offering a multitude of our workshops via telehealth, which run for 1 or 2 hours, which we know to be a length of time that our pain patients can sit for. So overall, what patients and yourselves need to know is that the time frame for referral, once we've received the referral for the first point of contact with that patient, lasts for 12 months. Unfortunately, as per Queensland Health policy, if we have 2 failed to attends for the patient, they have the possibility they will be discharged from the service. So those are just things to keep in mind about how the service works and our roadmap. There's our beautiful website, which we're oh so proud of, with all of the patient stories listed there. Again, cannot encourage enough for you to go and have a look at them. They're actually really quite heartwarming. Put those on instead of Netflix and chill this evening, people. So question and answer time. I believe that our wonderful team of OT and clinical nurse consultant have actually been able to answer most of your questions as the webinar has moved through this afternoon. So well done, ladies on the other end, for being able to get through all of those. But I think Ange is also going to, sorry, so Angela is our senior occupational therapist and also part-time team leader. She's just going to run through a bit of a summary of the patterns of questions that were delivered to us this afternoon. Oh, before I leave you, complete our satisfaction survey, but we'll probably say that 3 times before we finish.
Thank you, Carmen. Thank you, team. I'm sitting here with our persistent pain director, Dr. Tanya Morris, who's guided us in answering the questions. The general flavour has been the challenges of acute on persistent pain in a theatre situation, some information requesting resources about somatic symptom disorder. Is lignocaine an evidence-based treatment for persistent pain, which has been verified that there is some evidence for resistance-specific neuropathic pain being treated by lignocaine, and we do offer that. We've also had a few requests about copies of the slides. That won't be available. We've verified that, but there is a copy of the recording that will be available. So please avail yourself of that resource. I think that's the majority of the questions. We have replied all in most situations, so hopefully you'll be able to clarify any questions there. Thank you very much for your attendance. Please refer to our website and all the other resources. I'm signing out.
Thank you very much. And so I might take this opportunity as we close this presentation to have a moment where we can turn the camera on without compromising the whole network, just so that you can have an opportunity to see our faces, and we wanted to extend our thanks for your attendance today and for your questions, your interest. We've really appreciated the turnout. It's been fantastic, and so please do not hesitate to contact us if you need any further information. We've got as Carmen mentioned, we've got an excellent website. So I will flick on the camera and hopefully a bit of a wave. Let's see if this works. Okay, so thank you very much from behalf of the pain management service here.
Thank you.
All right. Thank you. So do I hand over to you, Jodie?